الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه أجمعين. Pneumoconisosis and Occupational Lung Disorders by Professor Mahmoud Hani Sulaiman. The term pneumoconiosis means dust in lungs, dust inside lung, equal accumulation of dust in lung and tissue reaction. So presence of dust in lung with tissue reaction. To its presence, it is usually restricted to conditions that cause a permanent alteration in lung architecture following inhalation of mineral dust. These dusts include silica, coal, asbestos. The clinical and radiographic features of silicosis, coal workers pneumoconiosis, and asbestos are summarized in the coming figure. This is the not normal anatomy at the upper on chest X-ray. Upper lung zones, lower lung zones, hilar region. To the left, simple pneumoconiosis. Lower is asbestosis, mesothelioma, irregular fibrosis, pleural plaques, and pleural thickening. On the right, complicated progressive massive fibrosis of coal workers, and this tuberculosis and calcified lymph nodes, which is a silicosis. This is the International Labour Organization classification for coding features of X-ray in pneumoconiosis. Small opacities are either rounded PQR and the profusion 1, 2, 3. Irregular type either STU and the profusion 1, 2, 3. Large opacities A large, B capital, C capital. Pleural thickening according to site of calcification, extent and width. Pleural calcification, site calcification, extent and width. Additional features for this classification: AA, atherosclerotic aorta; AT, apical pleural thickening; AX, coalescence of small rounded opacities; BU, bully, and so on. Print and use. Route of entry is by inhalation. Air exchange of region of lungs is about 300 square feet at rest and 1000 square feet at full inspiration. That is to say, about 3 times the lung at rest. Respiratory system, nasopharynx region, tracheobronchial region, and pulmonary alveolar region. Nasopharynx, tracheobronchial, pulmonary or alveolar region. This figure shows the composition of respiratory system, nasopharynx, tracheobronchial, and pulmonary, which is bronchiole and alveoli. Nasopharynx, tracheobronchial, pulmonary, and the pulmonary composed of bronchiole and alveoli. Particle deposition by size distribution. In various regions of lungs. Particles deposit in different regions of lung based largely on size of particle. So large particles at the beginning at the nasopharynx and smaller enters the alveoli. Dust disease. Pneumoconiosis are caused by inhalation and retention of lung of dust, include coal pneumoconiosis, silicosis, and asbestosis. Silicosis, while rock drilling, crushing also occurs in coal miners. Asbestosis in insulation workers because it is used in insulation of hot tubes, of tubes carrying cool air, and so on. This can produce fibrosis, carcinoma, and pleural mesothelioma. These are radiographic diagnoses made in light of patients' non-occupational hazards exposure. So, to diagnose, you need to know the occupational history and to make radiographs. Lung responses to workplace hazards. Lung responses to workplace hazards. The response may be diffuse fibrosis, nodular fibrosis, emphysema, chronic bronchitis, acute bronchitis, airway hypersensitivity, bronchiolitis obliterans, asthma, byssinosis, allergic alveolitis, bronchial carcinoma, and pleural mesothelioma. From below, pleural mesothelioma, the mechanism DNA damage due to asbestos. Bronchial carcinoma, DNA damage due to asbestos and chloromethyl ether. Allergic alveolitis, complement activation, cytokine release due to thermophilic actinomyces. This is an example. Byssinosis, endotoxin complement activation due to cotton dust. Asthma, airway hypersensitivity, for example, flower wood isocyanate. Acute bronchitis, airway inflammation, irritant gases and fumes. Chronic bronchitis due to airway inflammation due to dust and fumes. Emphysema, mechanism, neutrophil elastase release, coal and cadmium. Nodular fibrosis, macrophage mediated due quartz and coal. Diffuse fibrosis, macrophage mediated delayed hypersensitivity due to asbestos and beryllium. So in the exposure we have asbestos, beryllium, silica, quartz يعني, coal, cadmium, dust and fumes, irritant gas and fumes. All these are examples. Flour, wood isocyanate, cotton dust, thermophilic actinomyces, asbestos, chloromethyl ether, and asbestos. This is very important table. Occupational causes of lung cancer. What are the causes of lung cancer? This is the cause. This is the occupation. Some occupations which expose the worker to these agents. The cause: arsenic trioxide, arsenites, arsenic trioxide and arsenites, asbestos, dichromates, bis-chloromethyl ether, mustard gas, nickel subsulfide, polycyclic aromatic hydrocarbons, radon daughters. When you suspect cancer lung, you must ask about these occupations and these materials in the work. Clinical features of pneumoconiosis. In early stages, there are no symptoms, but X-ray changes occur. Later, there is dyspnea on exertion, cough, sputum, and attacks of bronchitis. Early, no symptoms, but may be X-ray changes, minute. Later, dyspnea on exertion, cough, sputum, and attacks of bronchitis. In coal miners, progressive massive fibrosis may occur, and in Kaplan syndrome, pulmonary nodules occur in association with rheumatoid arthritis. The patients may eventually develop cor pulmonale. So from no symptoms to dyspnea on exertion with cough and sputum, massive fibrosis, or with rheumatoid arthritis, at the end cor pulmonale. Now we will study silicosis. Silicosis occurs following inhalation of free silica, silicon dioxide, most common among workers involved in quarrying, mining, and tunneling through quartz-bearing rock during gold mining, for example. recognized in following processes: use of abrasives, sand blasting, glass manufacture, stone cutting and dressing, foundry work, ceramic manufacture. What you will ask in occupational history: workers at risk for silicosis. Sandblaster, exposure hazard during shipbuilding and ironworking. Mine or tunneler, underground mines are at risk. During roof bolting, shot firing and drilling, surface coal mine drillers are at high risk. Miller, pottery worker, glass maker, industry of glass, foundry worker, quarry worker, abrasive worker. As you see, this is a good list. It includes many industrial processes. Its prevalence is quite good. This figure shows foundry workers pouring metal into a sandfield form for steel manufacture. Worker on left controlling rate of pouring by preserving angle of deep crucible. Worker on right uses long pole with bar to prevent floating slag from getting into the form. There are unsafe practices occur, including absence of respiratory protection and absence of hearing protection and absence of face and body shielding or proper elevation of equipment for all workers present. Several forms of free silica are present: quartz, cristobalite, tridymite, fused silica dust, tripoli, and silica flour. Inhalation of crystalline silica, silicon dioxide, causes fibrotic changes in lungs. Four main clinical types of silicosis. Important: nodular, mixed, diatomite, and acute. Nodular, mixed, diatomite, and acute. Nodular with hyaline and collagenous lesions in lungs. Mixed dust fibrosis with irregular fibrotic lung lesions. Diatomite, a picture similar to fibrosing alveolitis, usually attributed to diatomaceous earth. Acute, rapidly developing alveolar lipoproteinosis with fibrosing alveolitis. So 4 types of silicosis: nodular, mixed, diatomite, and acute. Fibrotic lung lesions frequently calcify to produce characteristic eggshell calcification on chest X-ray. There is progressive restrictive fibrotic lung disease, which can lead to core pulmonale. Pulmonary tuberculosis used to be a common complication of silicosis. Silica may lead to lung carcinogen due to increased risk of lung cancer in silicotics and additive risk of cigarette smoking. This is the silicosis clinically. As you see, dyspnea. And this is the description of dyspnea. The process which occurs which will lead to dyspnea: abnormal and widespread infiltration of cells, fluid, and collagen into interstitial spaces between alveoli due to many causes. Timing of the dyspnea: progressive dyspnea, which varies in its rate of development with the cause. Again, silicosis clinically, the dyspnea is on exertion, begins on exertion. What relieves it? Rest, though dyspnea may become persistent. Associated symptoms: often weakness, fatigue, cough, less common than in other lung diseases. Varied setting according to the substance. Here the substance is caused the disease is silicon dioxide. Clinically, also there is crackles. Crackles are discontinuous non-musical sound that can be early inspiratory, as in COPD, late inspiratory, as in pulmonary fibrosis. It is late inspiratory in silicosis and asbestosis. Here, physical signs of respiratory diseases, but we will choose the fibrosis. Mediastinal displacement, none. Percussion note, normal or tympanic. Breath sounds, vesicular. Vocal resonance, increased. Added sounds, fine crackles. Inspiratory crackles, as we said. Symptoms start if and when discrete rounded opacities seen on chest X-ray coalesce, break down, or become more fibrotic. Serious pulmonary dysfunction then supervenes, and death is commonly due to cor pulmonale. Pulmonary function tests in patients with simple silicosis is usually normal, but occasionally may demonstrate evidence of mild restrictive ventilatory defect and decreased lung compliance. In addition, mild obstructive impairment is found. Occasionally in patients with simple silicosis, often as a consequence of chronic bronchitis caused by non-specific dust effects or smoking. With complicated silicosis involving progressive fibrosis, nodules more than 10 mm in diameter, increasing in dyspnea is noted, initially with exertion, then progressing to dyspnea at rest. Complicated chronic silicosis is associated with greater reductions in lung volumes, decreased diffusing capacity, and hypoxemia with exercise. Progressive massive fibrosis is the end stage of complicated chronic silicosis. These are the occupational causes of pulmonary fibrosis. It is the differential diagnosis for silicosis. As you see, asbestos, coal dust, quartz, beryllium, quartz which will give us silicosis, beryllium, cobalt, moldy hay dust. So these are for differential diagnosis of silicosis: asbestos, coal dust, quartz, beryllium, cobalt, and moldy hay dust. Chest X-ray in silicosis. On your left, a case of silicosis. Note nodules more in the upper lung lobes and more in the right lung. On your right, eggshell calcification of hilar lymph nodes in silicosis. This picture shows X-ray of 31-year, worked as a surface driller for 5 years. Clinically, he was accelerated silicosis. Aside from background small rounded opacities, note appearance of conglomerate opacities, the arrows, in outer portions of both lung fields. This X-ray shows 56-year surface minor with simple silicosis. The radiographic lesions consist principally of small rounded opacity distributed throughout upper, middle, and most of lower lung zones. There is bilateral hilar prominence, eggshell appearance, as you see. Here is progressive massive fibrosis in silicosis. Large mass-like opacities are present in both upper lobes. There is bilateral hilar retraction and basilar hyperlucency. Chest radiograph: an 80-year woman who worked in a pottery factory for 40 years. She was known to have simple silicosis for many years, but developed increasing dyspnea and deteriorating appearance on chest X-ray. Acid phosphorylated seen in sputum smears and identified later as Mycobacterium tuberculosis. Here, magnified picture of the nodules on your left. On your right, silicosis. Note large nodules, calcified lymph nodes, as arrows indicate. Here, on your left, chest radiograph of patient with advanced complicated silicosis showing bilateral upper lobe conglomerate shadows with retraction of both hilar regions, apical bulli, and basilar emphysema. Left apical pneumothorax is visible. Left apical pneumothorax. On your right is coal miners with coal workers pneumoconiosis. Here, chest radiograph of a 63-year-old worker with known silicosis. Very apparent. Complications of silicosis: mycobacterial infections, immune-mediated complications, progressive systemic sclerosis, scleroderma, or rheumatoid arthritis. Renal complications: clinical spectrum of silicone nephropathy includes glomerulonephritis, nephrotic syndrome, end-stage renal disease, and cancer. Treatment of silicosis: no proven effective therapy. As we said, airflow obstruction can be treated with inhaled bronchodilators. Antibiotics are empirically given to those with acute bronchitis. Oxygen is used to manage hypoxemia and associated pulmonary hypertension. Right side heart failure can be treated with diuretics. Because no treatment for silicosis till now, management done to prevent both progression and complications of silicosis. Exposure avoided and surveillance for TB done. Tuberculin positive persons with silicosis have about 30-fold greater risk for developing tuberculosis and should be treated for latent TB. Revise TB lecture. In acute silicosis, therapeutic whole lung lavage has been employed to physically remove silica from the alveoli. Now we will begin to describe asbestos-related diseases and conditions. The pathology, non-malignant pathology, the asbestos affects lung, leading to asbestosis, diffuse interstitial fibrosis, a small airway fibrosis limited to the peribronchial region, or chronic airway. Pleura, non-malignant affection is pleural plaque, visceroparietal reactions, including benign pleural effusion, diffuse pleural fibrosis, and rounded atelyx. Skin, there may be asbestos inclusions. Malignant pathology. In the lung cancer, all cell types, and cancer of larynx. In the pleura, mesothelioma of pleura. Other mesothelium-lined cavities may be affected. We have mesothelioma of peritoneum, pericardium, and scrotum in decreasing frequency of order. GIT and other organs with malignant transformations: cancer of stomach, esophagus, cancer, colon, rectum, ovary, gallbladder, bile ducts, pancreas, and kidney. So as you see, it is wide spectrum of diseases and conditions that is the agent is asbestos. Where asbestos is found now, asbestos is removed from all factories, but now it is present in all the homes. So you can find it around because it is insulating, boiler vessels and pipework ceilings, cladding to column, domestic appliance, flooring material, interior walls and panels, lining to lift door, roof and exterior walls, service seals, and other places inside all the homes. This is pictures of asbestos cement, corrugated floors on your left, and the insulating material done by asbestos and cement. This is sprayed asbestos for insulation. This is asbestos insulating board. Asbestos insulating board may be found at these places. Asbestos textiles, it was used to protect from heat. Several types of asbestos are present. We have serpentine, chrysotile or white A asbestos, amphibole and crocidolite, blue asbestos, amosite, brown asbestos, anthophyllite and tremolite and actinolite asbestos. So many types of asbestos fibers. Asbestos fibers produce more irregular and linear lesions. The silicon dioxide produce nodular, but asbestos produce linear. The disease is progressive and death from restrictive lung disease is common. Clinically, disease first present as dyspnea, non-productive cough, finger clapping or weight loss. Persistent chest pain frequently heralds a malignant sequelae, usually bronchogenic carcinoma or occasionally pleural mesothelioma. There is synergistic effect between asbestos and cigarette smoking in terms of risk of developing lung cancer. Asbestosis showing linear basal opacity, mainly at the beginning, linear basal opacity. Exposure occurs in mining, milling, processing, transport, manufacture, and disposal of asbestos. All these workers can be exposed to asbestos. Cement products like pipes, roofs, friction materials like brakes, brake linings, friction materials, paints, coatings, plastic, heat and electrical insulation materials, floor covering and brake linings. Investigation for asbestos-related disease. This shows asbestos spores in human lung, a few small uncoated fibers as the arrow, this is the uncoated, are also visible. The one like a dumbbell is asbestos spots at the beginning. This arrow indicate it. Here are chest imaging in asbestos-related lung disease. A posterior chest radiograph A shows asbestosis involving both lungs in the category of ILO 1 divided by 1 and bilateral pleural thickening. This is the bilateral pleural thickening. This is the graph A. This is the bilateral pleural thickening. Open arse and an ill-defined opacity. This is the ill-defined opacity. In left upper lobe on CTB, this is the CTB. This was shown to be dense mass. M. Abutting onto pleura and the needle biopsy revealed an adenocarcinoma of lung. On C, pleural plaques as indicated by the arrows. Pleural plaques. This X-ray shows malignant mesothelioma. On the X-ray found on your left, large mass in axillary region, note reduction in volume of right hemothorax and a marked irregular nodular thickening of pleura of whole right lung. Thickening of pleura of whole right lung. CTB shows extensive pleural thickening involving parietal and mediastinal pleura. This parietal and mediastinal pleura. Closed arms in and around ribs. This radiograph of 55-year-old shipyard worker with previous asbestos exposure showing multiple bilateral calcified pleural plaques seen as en face as well as in tangent. This is en face, this is in tangent. Linear and reticular pulmonary opacities suggest asbestosis and retractile pleuritis. Retractile. pleuritis. This radiograph shows typical calcified pleural plaques on your left A that are essentially diagnostic of asbestos exposure. Pleural plaques indicates exposure. High resolution CT scan demonstrates the calcified plaques B on your right more clearly, but does not add significant diagnostic information. This shows 50-year-old male asbestos-exposed cigarette smoker. The chest X-ray was read as possible asbestosis. High-resolution CT in the middle through the upper lobes shows changes of emphysema without fibrosis. A. The same findings are present in lower lobe. Prevention of asbestosis. In taking steps to prevent asbestos-related diseases, two important. Firstly, mesothelioma is almost always due to exposure to amphiboles. So avoidance of all use of these types of asbestos will eliminate the disease. In Egypt, asbestos excluded since 2005. However, most cases of mesothelioma occur in people working in effectively unregulated industry and in removal of old buildings. Secondly, asbestosis lung cancer develop in relation to the dose of asbestos to which people are exposed. While it is probable that risks of clinically significant asbestosis may be eliminated by preventing workplace exposure to more than 0.5 fibers per milli, over lifetime, these exposure levels may still entail a risk of developing lung cancer. Cancer from asbestos dependent partly on smoking habits of workforce, rising to perhaps 6 per 1,000 for men exposed to asbestos. Thus, prevention of asbestos-related disease depends on reduction or elimination of exposure to it. Currently, maximum allowable concentration of chrysotile is 0.5 fibers per milli, while use of crocidolite and amosite is effectively prevented by standard of 0.2 fibers per milli. Regulations also enforce wearing of protective clothing and full face respirators. Wearing of protective clothing and full face respirators by workers, removing asbestos, effective sealing of and vacuuming of such areas, and safe disposal of the waste material. Coal workers pneumoconiosis. Coal workers pneumoconiosis or black lung. This is the coal mining. The coming figures will show us different parts of coal mines. Coal mining, coal mining, coal mining. Clinical features of coal workers pneumoconiosis. In early stages, there are no symptoms, but X-ray changes occur. Later, there is dyspnea on exertion, cough, sputum, and attacks of bronchitis. In coal miners, progressive massive fibrosis may occur in Kaplan syndrome. Pulmonary nodules occur in association with rheumatoid arthritis. The patient may eventually develop cor pulmonale. Symptoms start if when discrete round opacity seen on chest X-rays coalesce, break down, or become more fibrotic. Serious pulmonary dysfunction then supervenes, and this is commonly due to cor pulmonale. Chest X-ray in coal workers pneumoconiosis. On your left, simple coal workers pneumoconiosis. A, type P, pinpoint opacities, very small. B, type Q, acronodular opacities, micronodular opacities, C, type R, nodular opacities typically associated with quartz exposure. Coal workers pneumoconiosis, extensive category 3, simple pneumoconiosis with early fibrosis, stage A in right upper lung. This X-ray shows multi-rounded lesions of Kaplan syndrome in coal miner with rheumatoid disease. This. Management and prevention of coal workers pneumoconiosis. There is no treatment for coal workers pneumoconiosis, and as for all pneumoconiosis, so prevention is a must. This is achieved by reduction of dust levels, again in coal mines, by a combination of improved ventilation and use of water to suppress dust and its source. Whatever dust standard is applied, some miners will get pneumoconiosis because of variations in individual susceptibility. So dust suppression is accompanied by workforce radiographic monitoring. This has the effect of reducing the risks for developing progressive massive fibrosis. A further measure is to offer miners personal protection by respirators. However, this is not regarded as a substitute for good dust suppression. وفي النهاية أقول الحمد لله و thank you for your good listening.